Welcome back to the Best PT Podcast, episode 3.13, Cerebrovascular Accident or Stroke. Different types of CVAs. A transient ischemic attack or TIA is a result of an atherosclerotic thrombus that blocks blood supply to an area of the brain. Symptoms of TIAs resolve within 24 to 48 hours. They most often occur in the carotid and vestibular basilar arteries. Warning sign of a future CVA is what a TIA is considered to be. A complete stroke is a CVA that presents with total neurological deficits at the onset. So a thrombus has blocked blood flow, damage has occurred, and the thrombus has already broken down. An evolving stroke gradually progresses from a slowly occluding artery. Deficits do not appear for 1 to 2 days. These strokes are most responsive to TPA. TPA is tissue plasminogen activator. It's a protein involved in breaking down blood clots. It's effective in strokes if given in the first 3 hours following a stroke. Ischemic strokes consist of 85 to 90% of all strokes. Embolus strokes are 20% of all ischemic strokes. An embolus can be a solid, liquid, or gas that occludes a blood vessel. The middle cerebral artery is the most common site of an embolus stroke via blocking of the internal carotid artery. These occur very rapidly, and they usually begin with a thrombus ischemic strokes are caused by atherosclerotic plaques developing with an artery over time until eventually occluding the artery. They have an extremely variable onset of symptoms that can appear in minutes or over the course of several days. They most often occur during sleep or after waking up following a myocardial infarction or heart attack or post-surgery. And then the 10 to 15% of all the other strokes are hemorrhagic strokes caused by abnormal brain bleeding that causes brain damage secondary to compression of the brain from excess blood. Hypertension is the largest factor in hemorrhagic strokes. Symptoms include a severe headache, vomiting, and a continual increase in blood pressure that increases throughout the day. TPA will exacerbate a hemorrhagic stroke because it is an anti-clotting agent. Stroke synergy patterns. The theory behind these is that higher brain centers lose control over movement after a stroke and become uncontrolled or partially controlled by middle managers of the brain. Upper extremity synergies. The flexor synergy is scapular elevation and retraction, shoulder abduction and external rotation, elbow flexion, forearm supination, wrist flexion, and finger and thumb flexion with adduction. The extensor synergy is scapular depression and protraction, shoulder internal rotation and adduction, elbow extension and forearm pronation with wrist extension, as well as finger and thumb flexion with adduction. Lower extremity synergies. The flexor synergy is hip abduction and external rotation, knee flexion, ankle dorsiflexion and supination, and great toe extension with toe flexion, so toes 2 through 5 in flexion. The lower extremity extensor synergy, hip extension, internal rotation, adduction, knee extension, ankle plantar flexion and inversion, and toe flexion and adduction. And a few brief stroke tests and measures. The National Institute of Health Stroke Scale is used to assess the impairments related to an acute stroke. The Functional Independence Measure, or FIM, provides a burden level by assessing the ability of the patient to perform both mobility tasks and activities of daily living. The Stroke Impact Scale assesses both physical and social disabilities due to a stroke. And then the Fugel-Meyer test assesses both motor, sensory, and balance impairments, as well as pain and range of motion. This test was created specifically to assess hemiplegia secondary to stroke. That's it for episode 3.13, talking about cerebrovascular accidents or strokes. The next episode, 3.14, will talk about traumatic brain injuries, TBIs. As always, the outline for this episode is in the show notes. Thank you for joining.